On-the-scene coverage of AHA 13 is supported by Janssen Pharmaceuticals Incorporated.
I'm Peter Block in Dallas at the AHA annual meeting for On the Scene. And with me is Deepak Bhatt. Deepak needs no introduction, from the Brigham and Women's Hospital, the Grand Master of Clinical Trials. Deepak, we saw a lot of clinical trials again presented today. The ENGAGE trial seems to be potentially a game changer.
Absolutely, and in fact, I think it's the biggest trial that has the potential to change practice coming out of this meeting. And it was conducted by my colleagues at Brigham and Women's Hospital. It was a trial of atrial fibrillation studying a novel anticoagulant, a factor Xa inhibitor, edoxaban, two different doses, a higher dose and a low dose, versus warfarin for anticoagulation for atrial fibrillation.
And the high dose and low dose actually made a difference as well, didn't it, in that trial? So not only do we learn that it is a good drug, but the dosing isn't a big issue.
Absolutely. So it certainly was meeting the criteria of non-inferiority to warfarin, but beyond that, significantly reduced bleeding, importantly reduced intracranial hemorrhage, and even reduced cardiovascular death. So in fact, both doses look pretty good, some subtle advantages to one over the other in terms of the dosing. I think the dose modification in the trial based on renal function, based on weight, an innovative approach to anticoagulation. So I think two important messages. One, we appear to have a new novel anticoagulant. But two, and perhaps the more important message, these novel anticoagulants really do work. We've got now 4 different agents, 4 different series of trials that show the novel anticoagulants cause less intracranial hemorrhage than warfarin, with various efficacy signals as well.
So the bands are big winners, I think.
Absolutely.
Yeah, okay.
Absolutely.
Well, let's move on because there are other trials here, some not as exciting. Radar atrial fibrillation, a ablation trial, sort of a little bit of a disappointment.
Right, looking at 2 different ways of atrial ablation. Of course, anticoagulation is to treat the stroke risk, but ablation can be very useful to improve quality of life, decrease symptoms, that sort of thing. And there were 2 different strategies that were studied. The overall non-inferiority primary endpoint was quote-unquote negative, but there were a number of other endpoints that showed some signs of promise. So I think we need to do more work in this area to figure out what the best mode of ablation is using catheters.
I mean, the pulmonary vein isolation business has always been a little tricky for me when I think about it. Is it really good to burn all the way around a pulmonary vein? And the whole issue with stenosis and all that stuff.
Right, though that seems to be less. The pulmonary vein stenoses have decreased through the
There's
years.
no question about that. But it just seems so logical that pinpoint ablation would be a reasonable thing to do, and yet it doesn't seem to make much difference, or at least it isn't non-inferior.
Sure, though again, I think there was some promise, in particular the 1-year data. It was a 6-month primary endpoint, but the 1-year data, there were some favorable signals.
Further, I'm sure we'll see further studies about that.
I hope so, at least.
Okay, so then we have the last, which is this FFR stratification of patients with coronary disease, and it evokes all kinds of issues with syntax scores and whether you should operate on patients and not operate on patients, and so forth.
So this is a registry, to be clear, not a trial, but still valuable information. And what it showed is that FFR leads to reclassification of a significant number of patients undergoing diagnostic coronary angiography. So some patients who wouldn't have gone on to PCI do, a counterbalancing amount that would have gone on don't go on to PCI. Some who would have gone to PCI go to CABG. So it more, I think, appropriately stratifies patients to medical therapy, PCR, CABG.
So essentially what we're saying is if you use FFR, you can stratify better. So let me ask you a question, because now I'm a patient.
Okay? Oh, okay.
And I have a bad LAD lesion angiographically.
I'd be happy to stent it.
I knew you would. That's why I'm asking.
Okay.
And a long, sort of 60% right coronary lesion, which I'm sure would be an FFR of 0.75. Okay, just for the sake of discussion.
Sure.
And you FFR my LAD lesion, and though it looks just nasty on an angiogram, in fact, the FFR is 0.85 or 0.86. And I say to you, after you tell me you're not going to stent it because you don't want the OIG to send you to jail for inappropriate stenting, I say to you, but Dr. Bhatt, how do you know that this is not an unstable plaque? Is it worth going the next step to try and figure that out? And is FFR sort of flawed in that situation?
So this is a terrific question. So FFR is best, first of all, in stable coronary artery disease. It really hasn't been validated in ACS. So if you were an ACS patient, I would just treat whatever I thought the culprit lesion was. If I felt a complete revascularization was needed for whatever reason, I'd do that. But assuming that you're coming in with a stable clinical scenario, and I happen to find that ugly-looking Prox LAD, if it looked tight, to be totally honest, I don't know that I would have FFR'd it outside of a trial that is in real clinical practice. But let's say it looked ugly, morphologically speaking, but it didn't look tight, and I did end up FFR it. I guess I would have to leave it behind if the FFR was really 0.85, but I wouldn't feel good about it, if the morphology looked really bad. And, again, I might give you a little bit more adenosine there and see if I can get that FFR to give me the result that my gut is telling me. But I think in the future, that's something to consider. Should we actually evaluate plaque morphology as well? Of course, there's been some work in that already.
I think that's where we're going to go in interventional cardiology once we really have an opportunity to not only figure out the hemodynamic importance, but the structural importance of a plaque. Then we'll really have taken a step forward.
Absolutely, because as we know from the basic science, it's those inflamed plaques that are killing us.
Okay, well, thanks very much, Deepak. And for On the Scene, I'm Peter Block.